Welcome, Duke alumni and friends, to this session of the Duke Alumni Forever Learning Institute, an interdisciplinary educational program organized in a set of thematic courses. I'm Jo Supranoff, Director of Academic Engagement with Lifelong Learning for Alumni Engagement and Development. Thank you for joining our program discussing our health. This program is part of our Discourse for Democracy theme, sponsored by POLIS, the Center for Politics, with the Sanford School of Public Policy. Moderating our discussion today is Professor Barak Richman. He's the Katharine T. Bartlett Professor of Law and Professor of Business Administration with Duke Law School. Welcome to the Forever Learning Institute, Barak.
Jo, thanks so much. And thank you, everybody who's joining us. I will say, as a preliminary remark, that one of the really terrific things about Duke is how so many different departments thinks about our health system and our population's health. And our panel today will feature 4 people, if I'm counting myself, from different departments. And I think all of us would think that interdisciplinary approach really is the best way to think about health and healthcare and health policy. So joining me on the panel is Katharine Bundorf from the Sanford Policy School, Schenita Randolph from the School of Nursing, and David Ridley from the Fuqua School of Business. I will let the 3 of them briefly introduce themselves and what research they engage in, and then I'll start off with a conversation. So, Kate, why don't you start?
Great. Thank you so much, Barak. And thank you for pointing out the interdisciplinarity of our panel, as well as the interdisciplinarity of Duke. It's a really exciting part of the university in the context of health. I'm Kate Bundorf. I am a health economist. I'm at the Sanford School of Public Policy. My research focuses on financing and healthcare delivery in the U.S. healthcare system.
Schenita, why don't you go next?
Yes, thank you. Good afternoon to everyone. My name is Schenita Randolph, and I'm an associate professor in the Duke University School of Nursing. And my research focuses around health inequities, particularly in communities of color, around HIV.
And David.
Thanks, Barak. I'm David Ridley. I'm a health economist at the Business School. And I echo Barak's comment about the fact that we do a great job on this campus of getting around and talking to other people interested in healthcare, and a lot of different schools at this university interested in healthcare.
Fantastic. So we are convening, I guess, exactly 1 week before Election Day. And I think part of the series of these webinars is to really take stock of the particular political and policy moment that we're in. So let me ask a general question that all 3 of you can tee off however you'd like. What particular issues should informed voters, informed policymakers really be thinking about? What should be at the forefront of their mind as they confront the health sector and the world of health policy? And we'll start with Kate, and then we'll go with Schenita and David.
Okay, great. Thank you. Thank you, Barak, for that question. I thought I would maybe highlight 3 issues that I think are incredibly important and have been on my radar screen for a while right now. So the first one is thinking about the kind of changing structure of our healthcare delivery system. And over, I would say, the last 10 to 15 years, there's been kind of increasing consolidation among healthcare providers. And when I say increasing consolidation, that comes in lots of different forms. You can think about physicians getting together into larger groups, those physician groups integrating with hospitals, private equity, bringing together different types of delivery organizations under one umbrella. And I would say from the public's perspective, it's a little bit of a sleeper issue because it's not obvious exactly, kind of what the benefits and what the harms are to our healthcare system of this kind of rapidly changing environment. On the benefit side, I think there was a hope that by making these larger organizations, we would maybe deliver care more efficiently and maybe in a more organized manner. But the downside is really thinking about the lack of competition, rising prices for healthcare, and some concerns that the benefits of these bigger organizations haven't really materialized in the way that we had hoped in the form of higher quality. So to me, this is a, kind of a difficult and kind of long-running issue that's on my mind, thinking about how the changing structure of the healthcare system is really affecting patients in terms of the type of care they get, how much they pay for it, and what their alternatives are in the market. I think the second issue that's really on my mind is thinking about Medicaid expansion. So when the Affordable Care Act was passed, there was a mechanism to expand Medicaid to all low-income populations within a state. There were some changes to the initial legislation facilitated by the Supreme Court decisions. And now we're in a situation where state Medicaid programs have expanded to cover low-income people in many states, but not all states. So those decisions about expanding a state's Medicaid program are, kind of a negotiation between the state and the federal government. But we have 12 states that still haven't expanded Medicaid to low-income populations, creating kind of an income disparity across states and folks' access to health insurance. And as healthcare gets more expensive, that becomes even more important. The final thing that's really on my mind is thinking about health equity and health disparities. So during the pandemic, we had a racial reckoning where we really thought, kind of thought hard, or was brought to our attention that we have really important disparities in access to and the delivery of care. I think for many years, researchers have been documenting these disparities. So the existence of disparities, I don't think was actually news to researchers and policymakers, but I think the increased focus on the potential and the existence of different structural barriers across different groups in accessing high quality care. I think folks are paying much more attention to that, and I think in important ways. So if I were to link it back to the issue of the Medicaid expansion that I talked about, where there's 12 states that haven't expanded disproportionately serve racial minorities, or the population is disproportionately made up of racial minorities. That takes our income, issue and turns it into an equity issue as well. And there are, lots of other examples that we can talk about. I think once again, I think the big change is kind of recognizing how structures and how policies have really contributed to these different types of disparities. So let me stop there and hand it over to our next panelist.
Terrific. I know we're going to come back to probably all three of those points. Schenita, what's on your mind? What should be on our mind?
Yeah, so picking up from where Kate just left off, definitely health equity. Equity in our health and our health outcomes is a top priority, I think, in the administration currently, as concerns things related to health, as well as in the legislation and when we look at Congress. I think that it's important that we have a racial equity lens as we're looking at this concern. When we consider that communities of color have higher rates of mortality and morbidity rates across chronic illnesses, it's really important that we consider that across the spectrum. I will share that, when we think about health equity, that it's not just thinking about folks from low income populations. It's not just only thinking about educational levels. I'll share real quickly that a personal story for me in the past month in dealing with my son and engaging in the healthcare system. I'm educated. I have a PhD. I make good money. I have insurance. Access to care was still a major issue. And so when we think about equity, it's not just racial equity, but equity across. And I think that we have to make sure that going into this, that we have that racial equity lens. Another thing that's important for me are models of care in our delivery systems. COVID really showed us that there are some things that we can do that will engage our patients and within our healthcare system in a more, when I think about continuity of care, for example, telehealth. Telehealth works. And so now we are looking at a system where there are organizations and systems that don't want to use telehealth now because they're not going to be billed the billing system is not the same. And so you get billed more if the patient actually comes into the hospital. And so how do we have patient-centered care and knowing that, these systems actually worked for us in COVID in some areas. And then there are still areas where technology needs to be improved, for example, in our rural areas when it comes to telehealth. And so considering our delivery systems and how we deliver equitable care is also at the top of my mind. And then the third, being a nurse for over 25 years, improving our nursing workforce diversity and our diversity within our healthcare systems is very important. One of the conversations that continues to come up within our systems is the conversation of diversity, equity, and inclusion. And we know it was highlighted in COVID, and I think we've known for centuries, just the inequities that are faced with communities of color. And it is important that our workforce is diverse and meeting the needs to respond to the populations of people in the United States that we are actually caring for. And so in an extension of that, we have historically Black colleges and universities who are producing a high number of the workforce. And so making sure too that when we think about workforce, that we are providing the resources to these historically Black colleges and universities to be able to provide this education in an adequate way. And so those are the three things that are on my mind. And I think that the common theme there is equity.
Terrific. David, you are exceedingly modest or exceedingly generous during your introduction. Instead of saying what you're an expert in, you thanked me for saying something good about Duke, but you're an expert in the pharmaceutical sector. And a lot of your research actually has had direct impacts on policy. Why don't you tell us about the year in drug policy and how that will affect not just how it affects individuals' lives from what happened in the past year, but also what might happen in the year to come.
That was a very generous and kind introduction, Barak. See, audience, not all lawyers are bad. Some of them are okay.
Only most of them.
So thank you, Barak. So I think three things of possible interest for viewers about pharmaceutical policy in the past year. I think first and foremost, the Inflation Reduction Act. It is going to cap for those of you who are on Medicare, it will cap your out-of-pocket costs. In 2024, it will be capped at $3,000. And in 2025, it'll be capped at $2,000. It also puts some caps on insulin out-of-pocket insulin co-payments per month at $35 starting next year. Does some other things as well with regard to price controls and penalties for raising prices faster than inflation. Okay, so that's number one, the Inflation Reduction Act addressing prices and copays. Second, I thought it was really fascinating in 2022, Medicare refused to pay for a drug that doesn't work. And maybe that shouldn't be surprising. Maybe Medicare shouldn't. Maybe that should always be the policy that Medicare doesn't pay for drugs that don't work. But that was something kind of new because this is an FDA-approved drug. So approved by FDA, but not covered by Medicare. Usually those go hand in hand. But FDA approved a drug that doesn't work, and then Medicare refused to pay for it. So many of you may be familiar with Aduhelm, the Alzheimer's drug. And many people are excited about that drug. And I think FDA approved that drug because it gives people hope, although maybe a false hope. And it does reward drug companies that work on Alzheimer's disease. We do want them to work on Alzheimer's disease. They've been trying and failing for a very long time. Hopefully we have some other drugs that work in the pipeline for Alzheimer's disease. I think the third thing I want to highlight is following up on points made by Schenita and Kate about equity and diversity. We've seen more and more efforts to diversify clinical trials. And I think we especially saw this with the COVID vaccine. There's a real conscious effort that maybe even slow down a little bit and make sure we're going out and reaching people. And and it may or may not be a good idea to slow down in an emergency like that, but it does show you that drug makers and the FDA are thinking carefully about this finally. What does that mean? It means locating clinical trial sites where people are. It means reassuring people that we're not going to see a repeat of Tuskegee, where patients were treated so badly, really maliciously. So those are the three things I want you to know with regard to drug policy. The Inflation Reduction Act addressing copays and prices, Medicare, for one of the few times refusing to pay for a drug, although I would argue rightly, and 3 efforts to diversify clinical trials.
Terrific. So there's a lot to chew on, but I actually think that there was a lot of coherence to what the three of you said we all should be thinking about. And in particular, I want to know how the macro industrial changes, the consolidation, how that is affecting other elements you described, like equity. Now, obviously, if you expand insurance, if we were to expand Medicaid, there would be some additional access that would be provided. People who didn't have insurance before would have insurance now. And that can only expand access to certain healthcare services. But a lot of what Kate and Schenita, and also David, but especially what Kate and Schenita said, is really independent from insurance access. Not just the difficulty of obtaining quality care in spite of having insurance, but also the limits of having real care delivery models that are patient-focused. How much is that a consequence of the consolidation? How much of it is driven by the larger structural changes that we're seeing in the healthcare marketplace? Kate, why don't you start with that, and then Schenita, I want to hear what you say also.
Okay, great. And that's a big, interesting question, Barak. So thank you for that. I guess I would say 2 things. I think that, Schenita made very personal a point that can sound a little bit dry. And that point is that just having health insurance doesn't, it's probably necessary, but not sufficient for getting, equitable, high quality care. Right. So insurance, I don't want to say insurance doesn't help, because it helps a lot. It provides financial, protection from the financial risk of healthcare spending. But we can't just, even if we do expand Medicaid in all states, we certainly haven't finished the problem of creating equitable access to healthcare. Thinking about the role that consolidation plays in that, as healthcare systems consolidate, the consolidated system serves both public and serves patients covered both by public and private patients, right? So once we have that healthcare system, and its performance is going to affect everyone in the market. Schenita talked a little bit about, changing what I would think about it as like value-based care or value-based payment models, really trying to change the way that providers are paid to promote whole person care. Some research that I worked on a few years ago showed that in very consolidated markets, providers are less likely to adopt those types of payment methods, right? So that's basically saying, if you are a big hospital system and you're negotiating with an insurer, and you're, figuring out how the insurer and the hospital system are figuring out how they're going to structure payment between the 2 parties, when the delivery system has a lot of power, it's less likely to accept or move toward, away from our current payment system and toward a new payment system that might expose it to more risk, but also kind of creates incentives for whole payment care. Whole patient care. How that translates to health equity is a little bit different, right? I think that, the things that I've been thinking about for the last couple of years, well, it's related and different, is when we're thinking about health equity and access, it's almost like we have to interrogate everything, right? Like, the different ways in which inequities emerge in our system, like there's so many, right? So I'll take, once again, I'll build from Shanita's example. Telehealth. Telehealth is awesome, for some people, and could be a source of perhaps overbilling, for other patients when, telehealth is not really, warranted or not particularly effective. So changing payment systems to either favor or disfavor telehealth will have implications for equity, depending on what types of patients are likely or less likely to use telehealth and which patients those benefit. Right. So that was like a long chain. But I think it's, increasingly important to, kind of think about that long chain and think about, when we make policy changes, who's going to benefit, who's not going to benefit from that, and how can we create policies that don't exacerbate existing inequities.
So building off of that, Schenita, so Kate says, look, and I'm going to paraphrase it a little bit. Maybe I'll even misrepresent her a little bit, but that's okay too. That's the prerogative of the moderator. The more consolidated these markets get, the more driven they are by single hospital systems, the less responsive they are to different payment preferences, the less responsive they are to moving away from fee-for-service. And they might also be less responsive to pursuing lower cost, innovative delivery models like telemedicine. From your perspective, think about, and I'm actually motivated in part by one of the questions in the chat, concerned about the current healthcare workforce and how many MDs and also nurses are really being driven away from the sector. Is that in part a consequence of some of these other consolidation trends? Is there something about the way we structure and pay for medicine that is driving some of the workforce issues that you're worried about?
That's a loaded question.
Loaded. I apologize.
That's fine. That's fine. It is a loaded question. So the issues around payment systems, is it driving the workforce development is the question, right?
Part of it, yeah.
From speaking with those who are working in the system that I've had personal conversations with, I say a part of it. Because I can speak as a nurse. As nurses, it is our goal. It is what we are taught. Why we went to school is to take care of our patients. It is an art and it is a science. And so whenever we are not in a position to be able to do that and to do that well in a safe environment, it does impact our decisions. I have a nurse practitioner friend. She went to be an NP. She's excellent at what she does. Recently made a decision that she had to leave the system. And she said to me, they're wanting me to bill this patient for 45 minutes in the room. And maybe I only spent 15 minutes in the room because that's all I needed to spend. And now I need to bill them. Just the billing pieces and the conflict that she was having ethically in that space caused her to transition. And she's an entrepreneur now, and she started her own practice where she's doing home visits and she's doing what worked in COVID for her patients. And so I think that is a part of it. Definitely is a part of it. I think to add to some of what Kate was saying, when you think about access and equity are not the same. And, we can't look at them as being equitable. And so there's so many factors to consider. And that's why I think that the workforce development is important. How we think about even educating our nurses and our healthcare providers is important. Making sure that we are preparing them for innovative delivery models of care, technology, the use of technology within our systems. We talk about equity, but do we have measures in place to be able to assess how equity is impacting health outcomes and how it's driving that? And do we have measures to be able to, raise a concern for a system that's not meeting those requirements? And so this is so much. It's very, very complicated. And I think that it will take collaboration across universities that are preparing systems, policy, lawmakers. It will take this interdisciplinary approach to address our current challenges.
I love that last part of your answer. I mean, I like the first part also. Describing it, I guess that's an alternative to centralizing the delivery of care in expensive facilities and consolidated health systems. You're describing an alternative method, not just telemedicine, but home visits, using a very different workforce. And you use that word interdisciplinary at the end. Well, instead of putting words in your mouth, what do you mean by interdisciplinary? What is interdisciplinary care?
Whenever you go to the hospital, you know, you may have to see a social worker, you may have to see a nurse, you see the physician, right? You see the nutritionist. Making sure that we are preparing the workforce to be able to do that now as they're preparing to get out into the hospitals or whatever the settings are. Working now with those disciplines to be able to, you know, think about how we impact the lives. Right now, we do it in silos. I know we do in nursing a lot. We're trying to change that shift. We do have a great collaboration now with the School of Medicine at Duke, and so just making sure that we're preparing the workforce for what it actually looks like and feels like whenever we're there, and thinking about community and non-traditional models of healthcare delivery. You know, it's circling back. Home visits used to be how we delivered care anyway. So thinking about non-traditional models of healthcare delivery in our communities, with our community-based organizations as well, partnering with them to deliver care, community health workers. And so just having a bold and an innovative new perspective of how healthcare is delivered.
David, does that community-based or patient-centered based healthcare delivery model, how does that relate to pharma policy? There's an interesting comment in the questions that accuses pharma of sucking money out of patient care and taking money out of the possibility of having people give appointments. It sounds like actually Schenita's saying maybe that's not a bad thing. Maybe we should focus care around the individual, around the home. Maybe that includes access to pharma instead of making appointments with physicians.
So 3 thoughts, if I may, Barak. So first of all, pharma sucking money out of patient care. What share of U.S. healthcare spending goes to pharma, do you think? I'll just ask the audience, maybe put answers in the chat. What share of U.S. healthcare spending is going to pharmaceuticals?
You got 25%, you got 40%, 15, 20, 30. Okay. Now you got lots of others.
Mark got it. So about 15%. How does that compare to, say, France? It's about the same. I think France made 14%. But we are typical of rich countries in spending about 15% of the healthcare dollar on drugs. Do we spend a heck of a lot on drugs? Yeah, we do. But we spend a heck of a lot on healthcare. So we spend more on doctors, hospitals, drugs, devices, everything in the United States.
Quickly, Kate, can you tell the audience what the other 85% is, more or less?
Hospital is the biggest share, then physicians, then other stuff, then pharmaceuticals. Wow,
David,
that was a pop quiz. My professor just gave me a pop quiz. That was so stressful.
Yeah, so hospitals and healthcare providers are big chunk of that spending. That's a non-competitive 15% to pharma.
What do you say that we pay? Our 15% is a lot more than France's 15%. Why is that?
We spend more on everything. Why do we spend more? For one thing, we're a rich country. We're richer than the French. We're richer than the British. We've chosen to spend a lot on healthcare. We are definitely an outlier with regard to the amount of money we spend on healthcare. Is that because we're rich? Is that because of other reasons? With regard to pharmaceuticals, I think if I were a small country, I would use pretty drastic price controls to keep my prices down, because then I could spend less and I'd have no effect on innovation. So little country, I don't know, what's Canada, 3-4% of drug spending globally? If they cut back on drug spending, they have no effect on innovation. Whereas the US at getting close to 50%, let's say 40%, has a real effect on innovation when we spend less. So I think we're conscious of that. We also have a lot of drug makers in the country, and they wield some influence. Why do we spend more on doctors and hospitals? Maybe some of the story there's market power. Kate started off by talking about consolidation of hospitals. We have pretty effectively limited the supply of physicians over time. In the chat, there's been some worry about the exodus of healthcare providers. And I think that's a legitimate concern. And I think if I were a healthcare provider, I would be stressed out. That's a hard job, made even harder in many cases during COVID. However, I don't think it's a problem when people exit. When people change jobs, I think that's okay. When businesses close, I think that's okay. In the restaurant space, we don't wring our hands when a restaurant closes. I mean, if it's our favorite restaurant, we wring our hands, but we know another restaurant's going to open. So it's okay when people change jobs. The key is, are other people willing to come into those jobs? And yeah, I think as far as I know, there's still a lot of people applying for medical school. Now, I realize that takes some time to materialize because there's some period of training, and I feel bad for people unhappy in their jobs, but I do think some turnover is healthy.
Kate, getting back to insurance for a moment, there's an interesting question in the chat here. It says, is there any hope to manage fees for uninsured patients? If the provider participates with insurance and agreed to average reimbursement of $1,000 for a surgery, how can they tell the uninsured patients that their fee is $2,500? I think that question kind of is a nice launching point to trying to understand exactly how insurance, what role insurance plays in financing healthcare, and why Medicaid expansion has become so fraught. So maybe a simple question is, why haven't all states expanded Medicare? I'm sorry, Medicaid. I should have said Medicaid. Why all states have not expanded Medicaid? And is there something to the story that private insurance is very different from Medicaid insurance?
Yeah, so two parts. Why haven't all states expanded Medicaid? So expanding Medicaid has been a process. So it's optional for states, and part of why states haven't expanded Medicaid, especially in the beginning, I think has political components, right? So, for example, when you hold on the Affordable Care Act among the public right after it passed, and you called it the Affordable Care Act, you get decently high support. But then when you called it Obamacare, you would get much lower support, right? So whatever, if you just change the name of it, not the content, people had very different political views. I think what this has turned into over time is a negotiation game between states and the federal government, right? So you can, we're kind of in the weeds here on the wonky policy details, but at the highest level, you can think of expansion now as I could expand the Medicaid program in the form that it has always existed, right? And the federal government, me being the states, the federal government will give me a pretty high share of the spending on that. Or I can negotiate with the federal government to expand my Medicaid differently. And now many states either have negotiated to expand Medicaid differently, and states are currently, including North Carolina, thinking about Medicaid expansion and thinking about how that expansion would work. So we're seeing kind of more variety in Medicaid expansions. Essentially, the federal government is paying a lot for the expansion. I think there is pressure on states. But states have diverse stakeholders who might want to see it look different, right? That's I think in some way, so that's also a double-edged sword. Like in some ways, that's good because we are experimenting with lots of different ways that Medicaid could look. In other ways, we have to think a little bit about the equity and diversity implications of the choices that states are making to expand their Medicaid, right? So expansion, we think in general would alleviate some of these issues, but you can think about things that work requirements might differentially affect different groups. They are more or less popular or, viewed more or less favorably in different states. So we really have to think through what those implications are. So the second part of your question, I think, is kind of related to this public or private insurance. I think we don't know that. I think that's an incredibly important question, right? So many states are moving from this traditional model where the state paid providers directly for medical care to contracting with private managed care companies and delivering Medicaid that way. So we have a question, is that better? Is that not better than the way it used to be? I think this is a very active area of research right now. Many states are making, kind of big, bold moves. And I personally think the literature isn't, or the evidence isn't quite there yet to say what the implications of this movement to private managed care organizations has been. I feel like I've disappointed my professor with an I don't know right here. So I'm going to leave it there.
Well, part of that, I don't know, I think, and by the way, David, when you ask people to respond on the chat on pharma, it just exploded. That's why David is such a popular teacher. He gets the students to get really involved. But part of what's apparently showing up in the chat is related to what you were saying and related to what Kate was saying also. So the government has monopsony power. The government can say, look, this is how much we're going to pay for a certain service. And Medicaid, of course, like Medicare, sets prices, and those prices are a lot lower than the prices that are paid for by private insurance. And I think that's what one of the people in the chat said, where if you go to the hospital and you have private insurance for one procedure, the private insurance gives the physician $2,500. If you go in as a Medicare patient, the provider gets $1,500. If you go in as a Medicaid patient, the provider gets $1,000. And by the way, actually, if you go in as an uninsured patient, sometimes you have to pay $5,000, but we'll leave that to the side. David, do you see the same thing in pharma, which is kind of what everyone was arguing about? In the United States, we've decided to let the market decide how much we pay for drugs. In most other countries, the government decides to pay what to pay for drugs. Kate's saying that to some degree, you have a trade-off going on between lower prices but maybe more constrained quality. Is that what we see in the U.S.? My reading of the chat is enormous resistance to the way the U.S. pays for drugs, that we're paying for too much, that the prices are too high, and we really should adopt other government price control systems. Is there a similar trade-off, though, similar to what Kate described with hospital care?
Great questions. And I agree with you that the action in the chat is amazing. We have really engaged alumni, and they clearly care deeply about healthcare and are very informed about healthcare. A lot of expertise on the chat. So it is odd that we set reimbursement for healthcare providers and set it much lower than commercial rates, and we don't have a government mechanism for drug prices, or do we? So in the retail space, I think we have a decent mechanism, but I think in the provider administered space, we have an awful mechanism. So in the retail, the drugs you get at your pharmacy, we rely on commercial insurers that do a decent job of negotiating lower prices, especially when there's competition. Competition keeps coming up in this discussion. Competition among hospitals, we worried earlier about consolidation, competition among drug makers. If there's two drugs in a class, for the retail drugs, we do a pretty good job of getting low prices in the United States. The chief medical officer at one of the insurers bragged that they were getting the same low prices as the British for the hepatitis C drugs, because there was competition. They played the drug makers off against each other. That's the drugs you get at the pharmacy. The drugs that doctors and nurses are administering to you in a hospital, we have a ridiculous mechanism. It's really silly. The Inflation Reduction Act might make it a little bit better, but the silly thing we do is reimbursed at cost plus. So we say, hey, provider, if you use a drug, we'll pay you back at cost plus. And so what's the incentive to keep costs down when you're getting paid back at cost plus? Well, there's no incentive. And so we have crazy high prices for a lot of drugs, especially cancer drugs, especially the drugs that healthcare providers are injecting or infusing. And just a quick plug, I have a little video, a little cartoon that we made here at the business school explaining this problem. Maybe the alumni affairs team can send that little cartoon out later. It's just a 2 or 3 minute video. But we have a really flawed way of paying for drugs, especially the injected or infused drugs administered by providers. In the other space, we're doing okay. Those are prices. Things I talked about at the top of my discussion where your out-of-pocket costs. We should separate those. The co-pays you're paying. And Congress did take some steps to address those recently.
Schenita, we're talking a lot about prices and how they develop in the marketplace, or I guess the quasi-marketplace in the US. And that attracted my attention to one question in the chat. I would be curious to hear some thoughts on how a for-profit capitalist growth model for healthcare, and healthcare is in quotes, is driving issues such as providers leaving the workforce, billing and ethics for nurses, high healthcare costs, et cetera, all combined with some of the poorest health outcomes among high-resource nations. Now, you are the only non-economist on the panel. Now, by the way, someone complained that there wasn't a physician on the panel. I consider you a provider, which in many ways is whatever. You're the provider in the panel. How much do you think that these workforce issues, how much do you think the shortcomings of what you see is a function of relying on market forces? And I'll just say, I can think of two answers. One is related to what you're describing before, these pressures for unethical billing. That might be a way that the marketplace is really subverting the role of good care and the role of providers. But on the other hand, I also see the possibility that some really ambitious nurses could go out there and really offer a meaningful and really valuable alternative to the delivery system that we have. How do you guys talk about economics and markets?
Yeah, so we do, in terms of preparation for nurses, talk about private insurance versus Medicaid, Medicare, what that looks like in terms of financing our healthcare delivery systems, to be able to think about population health and what that means in the care that we provide to our patients. I'm thinking about, as I'm hearing this conversation, I just really think about, again, I'm sorry to keep, stories are very impactful, but I'm thinking about my 17-year-old who in the last 2 months had some health issues, GI health issues, and was told that there is an infusion that I know that would probably help. However, I'm not for sure if your insurance is going to cover it. I'll probably end up putting him on this other medication because insurance will cover it. Being the advocate that I am for my 17-year-old child and having context, I refuse that. No, we're going to do the infusion that's going to help him. And there's a period there, right? My son gets this infusion in 24 hours. He's totally different. He feels it's like a night and day. Night and day. I was told that, we can't get him in a GI appointment until December. He's having real symptoms here. December, I shared with this person things that I normally would not say. I told him what I do, how long I've been doing it, and where I work. My son had an appointment within a week. And so it automatically caused me to be saddened that if I were not an advocate, and many patients do not know the context of even how to advocate for themselves, my son would have gotten a medicine that probably would not have been as effective because insurance was not going to cover it. I'm not from a low-income family currently. I'm educated. And so what about those people, right? Those people, because we're always talking about education level, low income level, lack of insurance, those who don't have access to care, as if we put them in those people. It impacts everybody across race, across gender, across socioeconomic systems. And, you know, we are real people, all of us. And so the system is working for what it was intended to work for. And there is a greed in our system, and we have to acknowledge that. And so, you know, there's the passionate answer, Barak, to my question, to your question that you asked me. It is unacceptable in this rich country of the United States for this to be happening. And for me to experience that in the last 2 months brings voice to this for me, even all the more. And when we talk about equity, we have to make sure that we're not just talking about low income and communities of color. It impacts all of us, and that's important too. But let's open up our eyes and realize that for the least of them, it impacts me.
So how do we make this, how do we expand advocacy for others?
That's a huge question. I'll go back to workforce because that's the space that I'm in, right? I'm an educator. So I think that making sure that we are preparing the current workforce and those that will come after it, how to advocate. Policy. We need to make sure that healthcare providers understand policy. Policy needs to be a part of our curriculums, and we need to increase that. We need to invite David to more of our courses and classes, and Kate and you, Barak. I think that's a start. That's just in the space that I'm in, that I can speak to that. I'm sure that people who are others in other spaces can speak to how in your space, and that's a question I think that we can pose to our own selves, or everybody on this call. How do I advocate in the space that I am planted?
I mean, Kate, the whole idea of advocacy in a market is almost, you shouldn't need it, right? In a marketplace, you have providers or sellers who are always trying to compete for the marketplace for consumers. Now, obviously, if you have a monopoly, if you have a consolidated provider sector, then there's going to be less of an incentive to really catering or addressing the needs and demands of consumers. But that doesn't explain all of the health systems. I think what Schenita is describing is real insensitivity or unresponsiveness to human needs. Why isn't the American market working like that in the healthcare sector?
Yeah, that's another big question. I think I would, and I want to build on some of Schenita's points here. And I'm also going to give a shout out to someone way up in the top of the chat who is from Detroit, because I'm also from Detroit. And when I was growing up, you know, everyone around me was part of the auto industry. And I remember a time in the auto industry when folks were talking about, well, the drivers of our cars are aging. And we came up with a lot of innovations in cars to make it easier for aging drivers to drive cars, like big cup holders and, you know, making buttons bigger and making it easier to get in and out. And they realized that the auto manufacturers realized that it turns out that everyone liked these innovations, right? That made it easier to drive a car. So when I think of, you know, Schenita's call for advocacy, I think we need advocacy to change the system. But I kind of wish, or I hope for a system in which you advocate, you don't have to advocate every time you walk into a provider's office, right? That, you know, a system that's kind of centered around healthcare delivery, you know, really targeted towards providing you and your family with the stuff that you need. Ideally, also thinking a little bit about the cost of those things and using care efficiently. So, you know, so it's it's not all, it's not all competition. I don't think we can get rid of everything if we, if I had a magic wand and I made all markets competitive, that would, it would help. It probably wouldn't take us all the way there. We'd have to think a little bit about how our public payers are structured, our tax incentives for health insurance. But I do think this goal of pushing the system to be more patient-oriented and having healthcare providers competing for patients, as opposed to having it take 5 months to get in to see a primary care physician, would be kind of a change in kind of an about face in how our healthcare system is currently working.
David, Shanita's example involved access to drugs, which of course is one of the great frustrations that a lot of Americans have, thinking that they don't have access to what they really, of the particular pharmaceutical product that they think would help. Now, part of that, I'm sure, has to do with what several people who have in the chat have described gatekeepers or intermediaries in the health sector, particularly in the drug sector. There have been some discussions about PBMs. You, of course, mentioned the idea. PBMs are pharmaceutical benefit managers that are intermediaries in the sector. A number of people have talked about different Medicare Part D insurance products. Maybe you could give an overview a little bit of what these intermediaries or gatekeepers are, and maybe you could also offer a little bit of advice as to how to handle them. And I'll be taking notes on that question.
Yeah, so several thoughts on this. First, with regard to how to navigate the system to get the medicines that you need. And secondly, some thoughts on Shanita's experience and how we might address that. Okay, so in many cases, there is access to a drug that's limited, and that can be for a variety of reasons. Perhaps there's skepticism about whether the drug works, or perhaps the insurer has negotiated a better rate for a different drug that it thinks is as good or almost as good. So how can you get the drug that you need? There's always some sort of backdoor, almost always some sort of backdoor. When a drug's on the preferred drug list, you often need prior authorization to get around that. And it's going to require some paperwork, and it's going to require some contacts. One entity that really wants you to have that drug is that drug's manufacturer. So one approach is to reach out to that drug's manufacturer. They will help you navigate prior authorization. And also, if the problem is that it's not covered by your insurer, then in many cases, they will give you that drug. They will give you that drug in part because they want to be able to tell the story that, yes, we charge high prices, but everybody can access it. So the manufacturer can potentially be helpful for you, and so can persistence. But I want to go back to a couple points made by Schenita. One is that it helped in the navigation that she could relate to the other person. Hey, I'm also a nurse. Hey, I'm also at Duke. And that really helped open doors. And it's just a reminder of how powerful it is to have patient and provider that have something in common. And that also speaks to the importance of a diverse labor force, that it's really powerful to have that provider who can relate to you and you trust that other person. It's a little off topic, but I saw today there's a study out about how Black boys are more successful in life if they've had a Black teacher in elementary school. They're more likely, so if you have a Black teacher in elementary school, this is especially true for boys, less so for girls, you're more likely to go to college years later. So the power of having someone who looks like you, that trusts you, is really important. I think another problem that many people, like Schenita in that case, face is a lack of competition. If there's another business across the street that's begging for your business, then you just walk across the street. But in most places, there is no competition. And then the question for a scholar like Barak, who's both trained in law and economics, is how can the government address that consolidation? But also, there's a question about whether we can expand competition beyond the boundaries of our county and our region. Schenita talked earlier about the power of telehealth. So if I can see a provider that's farther away, then it's less important that my market is consolidated if I can go far away more easily, perhaps through telehealth.
I think we either have time for one more question or one more comment. So let me just, first of all, if Kate said hello to Detroit, I'm going to say hello to Philadelphia. 30 seconds each of you. What is the priority moving forward? Okay, go ahead.
Unfortunately, I don't think there is one magic bullet that fixes this problem. I think that, you often hear, in the tech space and in other parts of the economy, like that if we just do this, we will fix it. I think with our healthcare system, it's not going to be that, right? Like, I think it's going to be, steadily marching along, trying to make, progress, at every step of the way. So sorry, Professor, there's no one easy fix. I'm going to punt on you.
That's a good answer. No, yeah. No disruptive innovation. No, healthcare is complicated. Schenita.
I think that the one priority moving forward is for us all to identify the space that we hold, whether that's within our own families, whether it's personal passion around healthcare, whether it's within our roles that we currently have, and get behind that and advocate and fight for it. And if we all do that, there are 78 participants on this call. And if we all do that intentionally, unapologetically, at least we're moving some needles in different spaces, and then there's a collective action.
I'll just add, it's really hard to do that in the health sector. It's hard to do that as a patient. I mean, the power dynamics are so thorough and so reinforced, even within the healthcare sector. As a provider, the power dynamics inside the system are really, really hard. So what you said, I think is really important, and it's also important to recognize that it'll take a lot of effort.
Yes, it will, but we are consumers of health, and let's start there. So everybody on the call, the next time, if you're going as a patient, you are a consumer of the service in which you are receiving. So shift that mindset as a start.
That's great. David, close us out.
So this has been a fabulous and fun discussion, and amazing to see such engaged alumni. I would say, Barak, I'm enthusiastic about what our state is considering, expanding Medicaid and ending certificate of need laws. Fantastic.
Well, Joe, I'll pass it back to you. I'll just also say thank you for bringing the four of us together and letting us have this conversation. It's been a lot of fun, and it's been also very fun to engage with alums as well.
Thank you so much. Thank you, Barak, for being an excellent moderator, and to all of our speakers. You guys gave us a wealth of things to think about as we go into this midterm election season.